time. Perfect timing, Shelley. All right. Well, I'm thinking we're coming up on noon, and to make sure that we have enough time for our discussion, we'll get started and hopefully a few more people will join us as we go. So I want to welcome everyone and thank you for joining us for today's Keeping Up with Knowledge Translation Seminar, which is hosted by the Maritime Spore Support Unit, or MSSU. If you're not familiar with the MSSU, we're one of 11 SPORE support units across Canada that support and conduct patient-oriented research. And we work in all 3 maritime provinces. So we have teams based in New Brunswick, Nova Scotia, and PEI. My name is Rachel Jackmantonio, and I'm the Knowledge Translation Coordinator for the MSSU, and I'll be your host this afternoon. And so before we go further, I'd like to offer a land acknowledgement that reflects my location here in Jabuktuk, or Halifax. And I want to begin by acknowledging that I am in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the treaties of peace and friendship, which Mi'kmaq and Wolastoqiyik people first signed with the British Crown in 1725. The treaties did not deal with the surrender of lands and resources, but in fact recognized Mi'kmaq and Wolastoqiyik title and established the rules for what was to be an ongoing relationship between nations. We are all treaty people. We at the MSSU are committed to developing authentic and meaningful relationships with Indigenous communities and to supporting the inclusion of diverse perspectives in healthcare research across the Maritimes. As a part of that commitment, we also recognize the histories, contributions, and legacies of the African Nova Scotia people who have been here for the last 400 years. So in today's session, we'll be looking at how to engage diverse patients and even more broadly publics in administrative health data use and governance. And our speakers will illustrate how engagement is shaping the work of the Health Data Research Network Canada, or HDRN Canada, and we'll all get very good at that acronym by the end of today's session. And so before we dive in, just a few housekeeping notes for everyone. So please, if you haven't already, make sure that your microphone is muted. We are recording this session and the video will be available on the MSSU website and YouTube channel afterwards. We've enabled closed captioning. So if you'd like to show those captions or follow along the live transcript, you can control that yourself in your Zoom settings. And if a question comes to you while our presenters are speaking, feel free to drop it into the chat and include your name if you'd like us to call on you so that you can ask it yourselves. So our speakers today, I'll introduce them, are Julia Birch. So Julia is the Public Engagement Fellow with Health Data Research Network Canada, or HDRN Canada. And in this role, she works closely with their Public Advisory Council and diverse members of the public on various projects related to health data. Prior to her involvement with HDRN Canada, Julia was the Patient Engagement and Training and Capacity Lead with the Newfoundland and Labrador SPORE Support Unit, or NL Support. Julia holds a Bachelor of Science in Neuroscience from Memorial University and a Master's of Human Nutrition from McGill University, and has practiced clinically as a registered dietitian. She's joined today by her co-presenter, Brian Cho. Brian is a Public Advisory Council member with HDRN Canada and also a patient partner with the MSSU. He is currently a resident physiotherapist at Halifax Infirmary, and through this clinical role, he's fortunate to interact with a range of individuals from all backgrounds and has become invested in aiding efforts to increase patient engagement in health research. He holds a Bachelor's of Science in Kinesiology from Dalhousie University and a clinical doctorate of physiotherapy from the University of Melbourne in Australia. Brian is also an acting board member of the Human Rights and Freedom Centre, formerly the Canadian Rights and Freedom Centre. So without further ado, I'll hand over to Julia and Brian.
Thank you, Rachel. Just give me 1 second and I'll share our slides for today. Someone give me a nod to make sure everyone can see it. Okay, perfect. So thanks again, Rachel, for the introduction. Brian and I are quite excited to be here today to talk about HDRN Canada. I'm glad, Rachel, you already got that acronym out of the way, and how we are meaningfully engaging with the public. So just a little bit about what we will be touching on today. We'll provide a little bit of context to what we'll be talking about in terms of health and health-related data. So what are they? Why are they important? How are they used? And then a little bit about the role of HDRN Canada and how we support researchers in using administrative and other types of health data. Then we'll move on and talk about some more practical examples of how we are meaningfully engaging with the public through our Public Advisory Council, which, as Rachel mentioned, Brian is a valued member of, and then a couple of projects that do have a focus on public engagement and health data. So what are health data? The way HDRN Canada describes health data, it's really information about the health services that people receive. So this type of information is routinely collected during your interactions with the healthcare system. So it could be a visit to the emergency room, it could be seeing your family doctor or another healthcare professional, or getting a prescription for a medication. Oftentimes this data is identifiable. So it has your name, a personal health number, an address. And this information is really important for providing care, for personalizing treatment, and for the continuity of care between healthcare providers. Increasingly, we are seeing a number of initiatives from governments and hospitals and other organizations who are focused on giving people access to their own health data. Oftentimes, you might hear the term personal health record. So people are really starting to understand the value of health data in their own care. We don't want to forget about, though, other types of health data that aren't really health data, but they're related to health data. So I'm sure many of you have heard of the term social determinants of health. So these are really a broader range of personal, social, economic, and environmental factors that can determine individual and population health. So things like language, income, immigration status, education level. And these types of data can be linked with health data to give us a more complex and really a better understanding of the healthcare system and health outcomes. So when HDRN Canada talks about data and health data, we're really referring to these broad types of data. So moving on to HDRN Canada and what we do. So as I mentioned in the last slide, people are really starting to understand the importance of having access to health data to stay informed in their own healthcare. But we know data is very valuable in the broader picture as well. And researchers know this, and they want to be able to access this data and use it. Because this really helps them to better understand disease, treatment, how the healthcare system functions, all sorts of good things. The issue is in Canada, as we know, healthcare and social services are delivered provincially or territorially. So each province and territory has their own healthcare system. And this means that oftentimes health research is conducted in single provinces. So this makes it a little bit tricky to learn from the different approaches that provinces use or take to solve health problems. Even if we are looking at the same type of data, because provinces will collect data differently, they'll call data different names, even if they're the same thing. So we're trying to compare apples to pears instead of apples to apples between provinces. This is where HDRN Canada comes in. So we are a pan-Canadian network of organizations working together to help researchers do more and better multi-jurisdictional data. So this is really important because when researchers have access to data from multiple provinces and territories, it is much easier to conduct new research on topics that affect us all, like things like wait times, mental health, chronic illness. So we are made up of a number of different organizations. And again, I'm glad Rachel already kind of defined the SPORE support units. So there are a number of SPORE support units that make up HDRN Canada, as well as universities, research institutions. This slide shows just a select few of the organizations that make up HDRN Canada, not all. And they are made up of provincial and federal organizations, like you can see Statistics Canada there on the slide. So we are funded by the Strategy for Patient-Oriented Research, or SPORE, that I'm sure many of you are familiar with. But if you're not, this is an initiative from the Canadian Institutes of Health Research, or CIHR, that focuses on transforming patients and their families from passive recipients of healthcare and health services into proactive partners who help shape health research and healthcare. So of course, public engagement and patient engagement is an extremely important thing for us at HDRN Canada. I do just want to make a couple of points before we move on to our public engagement efforts. One is that HDRN Canada itself does not hold data. Our member organizations do, and that's something that causes a bit of confusion sometimes. The other thing I do want to bring up is that researchers access de-identified data through us. So before I talked a bit about identifiable data, that's not the type of data that typically researchers will access. It does have all of the identifying information removed from it. So and I won't get into the process of how researchers can access health data through HDRN Canada, because that's not the purpose of today's session. But in general, we like to think of ourselves as the facilitator. So each of our network organizations receives health data from multiple sources. They link this data together, and then the identifiable information is removed. And this is the data that's made accessible to researchers. If anyone has questions about that process and more information about how we support researchers in this, feel free to send me an email, and I can put my email in the chat, and I can connect you with the right person at HDRN Canada. I know I've been speaking a lot. Brian, do you want to add anything before we kind of get into more of the public engagement components of the presentation?
Yeah, I'm glad you did make a mention of that last point, because initially through our talks in the advisory council, there was some confusion about how that council would advise HDRN in what capacity. Now it is made clear, like, HDRN does not dictate what type of data is collected, but I think through our work with the council, we've been able to at least speak with the different organizations working with HDRN and have an opportunity to voice any concerns or have direct input on consent forms, such as linking statements. I know one of our earlier projects was to read over a data linking consent form to see which parts of the form was too vague or needed improvement. So even though it is not directly involved in the collection of data, I really think work on the council has done a lot, and we've made a lot of strides in at least putting forward some points to consider when these organizations are actually collecting, and how that data is being processed and used, and even what is highlighted by the public to be, something to look forward and something to pay attention to.
Thanks, Brian. And we'll also get into a little bit later more detail about kind of the work of the Public Advisory Council and the different types of activities that members are involved in. So moving into HDRN Canada's public engagement efforts. So as I mentioned, we are funded by the Strategy for Patient-Oriented Research, or SPORE. So patient and public engagement is a very important component of our strategic plan. We did just want to mention, you'll see us using the term public instead of patient, and public engagement instead of patient engagement. And this is because we want to emphasize that HDRN data extends beyond that of patients interacting with the healthcare system, and it involves various other public stakeholders like communities, other care partners, health services recipients. I've been in many conversations, and I'm sure many of you have as well, who've been debating about the right term to use, whether it be patient or another term like person with lived experience or public partner or patient partner, because many people identify different ways, right? We're not going to get into that discussion today, but we did just want to acknowledge that this is the term that HDRN Canada chooses to use. So again, as an initiative of SPORE, or the Strategy for Patient-Oriented Research, we are committed to engaging with the public in a way that is continuous, substantial, and meaningful. And those words are taken directly from SPORE. And I know, Brian, you've had a lot of experience engaging in different councils and with researchers, and I'd say that sometimes the engagement is more meaningful and sometimes it's probably a little less meaningful.
Absolutely. And what's been quite nice about being a part of this council is the back and forth that is there between different research projects or documents that we have been able to consult on. Julia will probably speak to this a little bit later. I know it creates a lot of work for the researchers and people involved in these projects, but as someone who has sat on a few councils in the past also, the back and forth has been very nice to see. We see these documents evolving over time. Highlights are always made. to which parts of the documents or how the process has been advised on by the advisory council, and we get to actually see these change, and final drafts are always sent out beforehand for approval. So that's been quite nice. So I think the meaningful aspect of it has been a really good portion of it, because I think without seeing these projects evolve or seeing these tangibles emerge, it's really, it tends to burn some members out. So especially being on this council, it's been nice to see these evolve in real time and actually be translated into projects.
It's always nice to hear that feedback, Brian. I mean, the HDRN Public Advisory Council, we've really only been around for a couple of years. And of course, there's always things we can learn about how to better engage with our members of the public and our public council members. So I think we're always trying to improve how we can better engage, but it is nice to hear that we've been doing a pretty good job so far. So of course, we want to be accountable in our commitment to meaningfully engaging with the public. So right now, we're actually in the process of finalizing a public engagement plan for HDRN Canada. And what you'll see here on the slide is kind of a modified higher level scope with some example work streams and activities in the public engagement plan. It's important to note that when we were defining a scope for the plan, we did want it to complement and not duplicate the work of other SPOR support units and other health systems initiatives that already have a public or patient engagement focus, because there are a lot out there. So to do this, we did do a survey of HDRN member organizations and other SPOR entities that really form the basis of these different work streams that you see here. So some of the key work streams that I'll just highlight briefly, of course, the Public Advisory Council and all of the activities within that. Of course, Brian and I will touch on that a little bit later. Public-oriented communications is another one. You'll see this theme of communications coming up a lot during our discussion. But really, we want to help the public better understand the use of administrative health data, the role of HDRN Canada, and we're working on a lot of different ways to do this. And the other one that I'll point out is the knowledge sharing across public and patient councils and committees. So as I said, there are a number of different public and patient councils and committees happening in Canada already, and we want to kind of be able to bring all of that together. We are planning our first knowledge sharing summit that's hopefully going to be held later in the spring. And our goal for this is to really bring together kind of key stakeholders and experts in the area of health data and public engagement, and give them a forum to kind of share their work and have generative dialogue. So look out for more information about that in the coming months. Brian and I are going to touch on or focus on some of the key aspects of this plan that you'll see in red there on the slide. So the Public Advisory Council, as well as a couple of projects that have a data and public engagement focus. So Public Advisory Council, and we often call it the PAC. So now that I've defined it, I'll probably just try to stick with PAC. I'll give a brief overview of the group, and then Brian can talk a bit more about his experience as a member on the group. So an interim Public Advisory Council was established back in 2019, and this group was really responsible for establishing terms of reference for the group and to help recruit for the first full PAC. As per the group's terms of reference, the purpose of the PAC is to advise HDRN on how to best communicate with the public, as I mentioned before, to advise on its short, medium, and long-term priorities, to identify issues that they identify as important to the public, and to discuss new kinds of data, especially things like patient-generated data that our member organizations may consider collecting. For example, I know in the patient engagement space, patient-reported outcome measures and patient-reported experience measures are recognized as quite valuable. So those are the sorts of conversations that have been happening. The PAC is made up of 12 to 15 members, and we aim to be broadly reflective of the overall Canadian adult population in terms of geography, sex and gender, age, ethnicity, occupation, and socioeconomic status. Now, the group's terms of reference do outline some of our requirements in terms of membership that we have to ensure that the group is diverse. I believe Rachel will send out a link to those terms of reference in the follow-up email to this, so I won't get into detail. But a couple of those requirements, we do want to have at least 3 Francophone members, and one of these members should be residing outside of Quebec. We also try to have at least 2 Indigenous members on the council. And at least half shouldn't have any sort of prior experience as a patient or public partner, because we do want to make sure the group is reflective of the general Canadian population, as I said. We also try not to have anyone on the council that has a lot of previous experience in health data or data privacy, because we do find that either subconsciously or not, members may defer to these individuals in discussions, and we don't really want that to happen. So before I move on, Brian, do you want to talk a little bit about your kind of experience on the group and the diversity of it?
Yeah, so the group, we meet up to 5 to 6 times a year, depending. This is quite flexible because different projects can be sent out by any members of HDRN to seek advisory on upcoming projects. And I can say that we do have a great group. We were missing one Indigenous member for the last term, which I think recruitment efforts are always ongoing. So just a quick plug, if anyone is ever interested, please reach out to us. And I say that because it's a unique environment in that we, at least at the council, or the majority of individuals there are really open-minded and allow space. And I think that's just so important to both have minority opinions emerge and then people actually feel safe to voice dissenting opinions, because I think we have had disagreements with the group, but these disagreements have been very important and certainly been learning moments for me. So I always welcome more diverse groups and more diverse voices in the group, and importantly, really support efforts in making individuals feel welcome and safe to voice these in a very non-judgmental space, really, because I think that's really important. Because if we continue to sort of gloss over these, it runs the risk of never being addressed. So I can say my time with the council has been incredible. We can talk about EDI initiatives a little bit later, but there's real-time French translation, and there's always room for different voices to put forward their opinion.
Thanks, Brian. I'm actually just seeing a couple of questions come in the chat. We can probably touch on those right now, if that's okay. Yeah, the question around disability is included within the diversity matrix of the group. Absolutely. And related to this, I see the second comment about the recruitment process. We just finished a recruitment process, so this is quite fresh in my mind. But we do interview people. So the first is kind of a mini survey that's sent out to anyone who's interested. There is a group that's assembled from members of HDRN Canada who are involved in the public engagement aspect of our work. And there is kind of a mini application survey that's sent out to anyone who's interested. And then we do shortlist based on trying to ensure that the people that we interview are the most diverse in terms of those factors that I mentioned before. But disability is absolutely something that we look at. And even in this last recruitment round, we were quite keen to interview people who had either identified as someone living with a chronic illness or a disability. So that's something that's always on our radar. And then after we do kind of shortlist and do the interview, then it's kind of a second shortlist to make sure that the group again is as diverse as possible. And we're always looking at the existing members that we have as well, right? So I mean, it is tricky because oftentimes the majority of people who apply to be part of groups like this are extremely, they have extremely interesting backgrounds. They have a lot of good things to bring to the table. So it's not, the process is not about saying we don't think you'd be a good fit. It's about, okay, well, we already have someone, or we already have a number of people that are older. We really need to get a younger representation. So we're going to choose you because you are only, you're 20 versus an older person. So it's really about taking that bigger picture and looking at that diversity versus kind of seeing if people would be a good fit, because the majority of the time they are. Yes, youth. So, and honestly, I will say engaging with youth is challenging for a couple of reasons, of course, because the way that you engage with the youth is quite different than the way you would engage with an older population. I feel like I can kind of speak on both because I feel like I'm kind of in the middle there. I'm not young and I'm not old yet. But even how you reach out, whether you're using social media versus other mechanisms to communicate, and then even in the way that you interview them and the questions that you ask, And then if you have youth on the council, you do need to be often a little bit more flexible, because if you're talking about older individuals, oftentimes we'll have people who are retired that are looking to volunteer or engage while they're not working anymore. But these younger individuals, a lot of times they're in school, they're often studying healthcare and other relevant fields, but being flexible in terms of meeting times, and accessibility options and all those sorts of things. So it's something different to think about, but we do try to prioritize getting as many kind of youth perspectives as we can. I'm just reading the other questions, and I hope I've answered as well as I can the ones that have already come in. I'm curious who is doing the interviews. Are the PAC members a part of that? So that's a really good question. So HDRN Canada has a public engagement working group. And this working group is made up of individuals from HDRN Canada, as well as some other individuals that aren't necessarily from HDRN Canada, but other stakeholders within the SPORE network. And so in the past, it's been a couple of different working group members who have conducted the interviews. Now, it's a very good question about whether PAC members are part of the interviews. They haven't been, to my knowledge, up to this, but I will say that that's probably something to consider. What do you think about that, Brian?
Sorry, I'm muted. It's definitely an interesting point.
Yeah.
Again, this is why I love these conversations, because just having someone just highlight something like this just jumpstart some conversations. It will always, I'd be open to it, but again, I can't speak for other members of the PAC as well. Might be something certainly worth visiting. We have another meeting this evening, and with your permission, Julie, we might be able to print it up with Frank and see if there's any interest. I think it'd be a good idea. There's probably some processes that I'll have to go on in the background before rolling something out like that, but yeah, certainly. Love that, actually, particularly if there are groups from different backgrounds or minority backgrounds to have some input on the recruitment process. It'd be actually amazing. Yeah.
And I think, in the whole spirit of SPORE, the strategy for patient-oriented research, they really focus on patient or public partner representation in all levels of governance, right, within an organization. And I know in previous, even in my role at Newfoundland Labrador SPORE Support Unit, we did have patient partners on our patient advisory council be involved in interviews for different sorts of things. So I think it's an excellent thing to consider, for sure. I see there's another question, but yes, we can absolutely answer that on the at the end. Oh, Can they also help frame interview questions? Yes, absolutely. So we actually went through kind of a streamlining of the interview process, because we did get feedback from the first cohort of PAC members that the interview and the kind of recruitment process was quite onerous and long. So based on feedback from PAC members, we did kind of streamline and change the interview process to make it a little bit easier. One of the interesting things we did this year was, instead of asking people to fill out a survey or a little online application form or Word document, we said they could also do a video answering the questions in a more visual or speaking format, which would definitely be kind of desirable for other people if they didn't want to fill it out online. We didn't get any video submissions, but maybe the next time. I think I've got all the questions, so I think I'll move on if that's okay with everyone. So feel free to keep asking the great questions. Again, we're still on the PAC. So Brian has touched on this a little bit, but in terms of, we'll just outline some of the activities and advice that's been provided by PAC members in the past, say, two and a half years. So they have provided feedback on the HDRN Canada strategic plan. So particularly around suggesting using more accessible and plain language, defining certain terms. For example, I believe the term Indigenous data sovereignty was used, and a PAC member suggested that we should define this. Not everyone knows what that means. Adding more detail about HDRN Canada's commitment to privacy, So those were some great comments that were integrated into the final version of the strategic plan. I believe Brian mentioned this is already, but they, they often provide feedback on other texts that are created or developed by HDRN Canada. So for example, on the content and clarity of text that was written about patient consent and the secondary use of health data. Again, this idea of communication is coming up. They have identified communication as a very big priority for HDRN Canada. So in the discussions, we've really brought up questions like, how can we as a network communicate more clearly with the public about what we do? What types of data do our member organizations hold? What is the benefit to members of the public for this type of network to exist? And these types of discussions actually led to the development of what we're calling a data grid. So this is a table which summarizes the type of data that each member organization of HDRN Canada holds. And it defines the types of data in quite plain language. And we're actually in the process of getting that up on the HDRN Canada website. So that should be available shortly. Brian, and I know you were kind of involved in those discussions about the data grid way back before I was even involved with HDRN. So I don't know if you want to expand on that a little bit before we keep going.
Yeah, absolutely. This was another really great example of, I guess the term living document has been used a few times in the research world, but in short, again, just consulting back and forth from different PAC members about the language that's contained in the grid. So for example, some of the administrative data descriptors were pared down to a little bit more plain language. One of the contributions that I found was quite nice was the shading initially was actually different colors, but me being colorblind myself, we made a couple comments about how the shadings were a little bit hard to distinguish. And again, right away, the grid was changed to more of a black and white format as well. So it was, again, just a really good example of how the work between the council and HDRN at large is always sort of conversational and back and forth. So the data grid has been really, really great to see emerge and see actually that the changes happen in real time. I know I sound like a broken record, but it's really just nice to see your contributions actually translated into the project.
Thanks, Brian. And actually, that your little comment about the colorblind and the changing of the colors, that brings us to the next point about this idea of IDEA, or inclusion, diversity, equity, and accessibility. And I know we could talk about this for a very long time. And again, it's not the main focus of the session, but we did want to bring it up because it is an important part of the PAC and an important part of HDRN Canada as a whole. So, I mean, in terms of IDEA, HDRN Canada's work, it is informed by best practice in IDEA, as well as Indigenous-led data sovereignty. And, we all know that inclusion is very important. It's really integral to ethical, really, and effective public engagement. So HDRN Canada itself, we do have teams for IDEA and Indigenous data sovereignty. So, and Brian can again speak to this, but the PAC, as well as those involved in public engagement at HDRN Canada, we very much collaborate and seek advice from the IDEA and Indigenous data teams to ensure that best practices are reflected in all of the public engagement activities. The PAC members, they actually have expressed interest in forming kind of an interest group in IDEA. So this would really just be a subgroup of members within the PAC who want to focus on, do a little bit more work and provide a little bit more feedback on IDEA. And Brian is actually a member of that group. So I don't know if you wanted to speak a little bit more in detail about that as well, Brian, before we move on.
Yeah, absolutely. I mean, I think this work is always, it's a passion project of mine, obviously, but it runs, it's tough because I think it can feel quite gigantic. But I do want to stress IDEA principles are something to be integrated in every effort. And this is more, again, trying to elevate and amplify voices that really need to be heard in healthcare. The other difficulty that I think these types of works might run into is still operating within a larger cultural sphere where works like this are, it seems at times like the general culture is sort of pushing back on it. We can talk at length about how the late Queen Elizabeth, and that news was handled recently, even in different parts of the world. So all of that to say that I always welcome any input. We're trying to, at least in the PAC space, I think we got some interest in some of the newer members that were recruited this year to see how this evolves and emerges in the next couple of months, hopefully. Again, I seek any voices, really. If anyone has anything to add or help, I really, really value a very open floor and open discussion. So I will listen to everybody. I'll say that right now. And I welcome anyone who thinks this is a good effort, and hopefully I can support in those efforts also.
Thanks, Brian, for that. Well, I know we're over halfway through the session, so let's switch gears a little bit and talk about a couple specific projects that HDRN Canada has been working on or is just in the process of finalizing that have a health data and public engagement focus. And of course, Brian has been involved in both of these projects, so he'll have a lot to say about them as well. So the first project that we wanted to touch on is the Health Data Social License White Paper Project. And this is a project that was actually funded by the Public Health Agency of Canada. The main idea here about this project is that members of the public see health data as an asset that should be used for public benefit, but their support is conditional. So what I mean by that is that they believe that there are certain requirements that need to be in place for uses or users of health data to be socially acceptable. And I'm sure we all can think in our heads right now about what you would think would be essential for someone to use your health data, for an essential requirement to be in place before that happens, right? So in terms of a couple of definitions, just so we're all on the same page, in case anyone doesn't know, but I'm sure most of you do, what a white paper is. A white paper is just a report to educate readers about a topic, and oftentimes it will identify potential solutions or recommendations on this topic. Now, the term social license is a bit of a trickier, interesting one. It's kind of evolved in the past couple of years about how it's being used, but in plain language terms, it's really a kind of informal agreement between stakeholders of the public and an organization, or it's really a permission for an organization to perform a certain type of work that will affect the community or the public. So it is possible for an activity to be legally allowed, but outside of social license. Increasingly, this term is being used to describe what health data related activities have the support of members of the public and under what conditions. So if we say that a use or a user of health data is within social license, what we're saying is that this is a use or user that at a minimum is publicly accepted. And ideally it's a use or user that has active public support. And when I get a little bit more deep into the findings of this paper, I think it's more easily understood when we have some concrete examples. So this project synthesized input from over 30 experienced public and patient advisors about two kind of main things. One being, what are some essential requirements for a use or user of health data to be within social license? And two, what are some specific examples of health data uses and users that participants agree are within or not within social license? So as an example, an essential requirement that someone could identify could be something like, there is transparent and plain language about how health data are used, collected, shared, reused. An example of a use of health data that could be within social license, and this is an example that all the participants in this project identified as being within social license, could be something like health data that's used by university-based researchers to understand the drivers of disease and well-being. So I hope that makes things a little bit clearer for people. Conversely, an example of a use of health data that people may think is outside of social license could be something like identified health data being sold or resold by a person or organization. So you can kind of see the differences in how people feel about health data being used. So I did want to note that while the process was to put together this white paper was facilitated by HDRN Canada and our Francophone partner, which is out of the University of Sherbrooke, the paper just includes the perspectives of members of the public, and they are included as co-authors on the paper, which is really great. Brian and I did want to touch on some key points about the public engagement and the methodology of the project, as I think it was quite an effective way to gather kind of valuable input from a very diverse group of people. So to get the input, we did gather groups of people on a couple of different occasions to discuss these essential requirements that I just talked about for health data social license, and also to discuss and hopefully come to consensus on examples of health data uses and users that are within or not within social license from their perspectives. So to help the group come to consensus on some of these examples, we did use what we're calling the 5-finger facilitation method. So how this worked briefly is the facilitator would present a statement like the example I just provided. So they would say it is within social license for health data to be used by a university-based researcher to understand the drivers of disease and well-being. And then participants would show how much they support this example using their fingers. So if they gave 5 fingers or an open hand, they completely supported the example. 0 fingers or a fist would be, no, I do not support it at all, or anywhere in between. And then 1 or 2 people who strongly supported the statement would be asked to kind of say why and provide some background information as to why they felt that way. And then the same for people who completely opposed it. Oftentimes this discussion would lead to changes, wording changes in the statement, which was really interesting. And then we would say that the group came to consensus on an example when no one had a closed fist. So some people could maybe only have 2 or 3 fingers up, but in general, we would call that consensus. So for example, in the other example I provided, so it is not within social license for someone or some organization to sell or resell someone else's identified health data. The group only came to consensus on this example after we changed the wording. So we actually added the word organization. So it wasn't just someone, it was someone or some organization. And we added identifiable health data. So it wasn't just health data in general. The other aspect of the methodology that we did want to just briefly touch on, because it's really important, is the inclusive design of the process. So this paper not only kind of identifies views and requirements that were supported by many participants, but it also highlights views and requirements that were supported by just 1 or 2 participants, which is interesting. And a lot of the work in this area doesn't really do that. So we did take this approach for a couple of different reasons. We know that people who hold minority views are least likely to be served by the status quo. And we also know that it's these people who are often holders of knowledge that is essential to design processes and policies that work for the entire population, not just the majority. So we did want to include these views because they are less likely to be reflected in the current literature around this health data social license. I will just give an example of some of the minority views that did come up during the discussions. So there were a small number of participants who felt that health data controls, safeguards, regulations should be proportionate and not so burdensome that they prevent benefits from being obtained from health data, compared to the majority of participants who were quite focused on ensuring proper security and controls to prevent privacy breaches. So you can really see kind of that there's 2 ends of the spectrum. I also want to acknowledge too, before I forget, that this approach was very much inspired by and informed by the work of Jutta Trevianis, who is the director of the Inclusive Design Research Institute at Ryerson University. She does a lot of great work in inclusive design. Brian, do you want to add anything before we kind of move on? Because I know you were quite involved in this project.
Yeah, absolutely. Just a quick point, because I think this is a really important project to be a part of. That's why I actually elected to hopefully be a part of this. We had a great group of people working on this. We met at least 3 or 4 times with the option of having independent meetings with different members of the group should the need arise. And certainly myself, as someone who is very biased and pro-research, it was really nice to see different and challenging voices in the room, because it really made me kind of step back and reflect on what was acceptable to me, and how this data will be reused. And social license is such an interesting concept in the data field, so I'm really interested to see how this actually evolves going forward, because we'll touch on this a little bit later. I really think this is a really powerful space to improve health equity going forward. So it was really, really nice to just be able to sit there and see minority voices amplified in the room, and then also just some very good back and forth with individuals that were more than willing to discuss even controversial or contradicting opinions with each other.
Thanks, Brian. And this just reminds me, because there were some questions about recruitment for the PAC. The recruitment for this project was quite similar in terms of trying to make sure the group was diverse as possible. But at the same time, the views that are expressed or in this paper are from, experienced patient and public advisors. So we did want people who had some sort of existing knowledge, just so we didn't have to start from zero. And that is one of the limitations of the paper too, that, in future work in this area, it would be good to kind of expand on that and hear perspectives from people who literally have very little knowledge about this as well. So just something that I wanted to note. And before we move on to the second project that we'll touch on, the paper is in its final stages, and we're hoping to share it publicly quite soon. So keep an eye out for that. But I did just want to share some of the essential requirements for health data social license that came up during discussions, because I think they're quite interesting. And it'll give you, again, a bit of a more concrete picture of the type of what was discussed during these meetings. So as you can see here, a lot of the discussion was focused on plain language about health data use by commercial organizations, and related to this, the selling of health data use and why people agree with this or don't agree with this, as well as personal control over one's own health data. For a little bit of context, at the beginning of the process, the participants were provided with a list of requirements that were identified from previous work in this area to kind of prompt their thinking and also prompt a discussion, but they were instructed not to feel constrained by this list. So the list contained, I think it was 40 essential requirements that were organized into different categories, and you can see the categories here in blue. And our thought at the beginning of the process was that we'd be able to kind of whittle down the list to get a very concise list of essential requirements that this group felt were the most important. But conversely, at the end of the process, instead of making the list smaller, the list actually grew to almost 85 essential requirements. So people were adding a lot of requirements they felt weren't already out there in the literature. And the other interesting thing was that every single requirement was identified by at least one participant as being essential, which I think reflects really two things. It reflects the diversity of the group that we had involved, and it also shows the complexity of this topic and of health data social license. I see there are some questions, or one question, I'll just read it. It's an interesting problem to make information like this accessible to folk who are more naive to the work. How do we make safe spaces to share info and hear views that reflect more diversity to make better decisions? Absolutely. And like, that is one of the limitations that we have actually brought up and written directly in the paper, because again, engaging with the public in this manner, it can be challenging, but I think it's something that does need to be done, whether it takes longer, whether it is more challenging, it's something that needs to be done. So always something that we're working on. Brian, I don't know if you want to add anything to that as well.
Yeah, I'm just, it's such a good comment.
Yeah, I know.
And I'm saying this as someone, I realize I'm also not reflective of even my own background, having been raised in Canada and speaking English to this point, and being able to understand these documents. So it's always difficult to create any space where minority opinions feel completely safe. And in fact, for myself, I think even comments like this are so good to have, because what makes me nervous is not so much the things that I think I'm seeing or things that I think I'm aware of. It's things that I might miss completely because of my own personal biases. And I know that doesn't really answer your question as well, but can I just say that's a great comment and something that I've thought of at length. So again, I'm very open to any suggestions or any feedback, really. And I think really importantly, for me, it's about engaging with the communities first. I think trust is so easily broken, but it can take like a lifetime to build up. And even if it's non-malicious, I think it really runs the risk of disconnecting some groups because there's a lot of history in some of these. I know that's a lot to put on everybody, but especially in this day and age, I think it really is upon us to really understand that and it shouldn't be on these groups to educate everybody.
Yeah, and it reminds me of a common, I guess, challenge within patient-oriented research or when you're engaging with the public is oftentimes we all recognize that getting diverse opinions is extremely important, but oftentimes when the people we're trying to engage with, inherently we're not going to reach them. If we want to and try to engage with someone that has low socioeconomic status or lives in poverty, they're not going to be the ones that are looking for, a SPORE support unit newsletter and all those sorts of things. So inherently this type of work, the way that we even communicate really needs to be looked at, and we're kind of in an echo chamber, I find, especially when you're living in quite an academic environment. We're all in a bit of a bubble. So it's always good to get comments like this and to kind of take a step back and see how we can better improve our processes and how we're working to engage everyone. Thanks for those comments. I know we only have about 10 minutes left, so I will very quickly, and at least I know we were supposed to have more time for discussion after, but at least you've been having some discussion throughout, so I hope that's okay. The second project we really did want to touch on, and this is a really interesting one. We just briefly mentioned actually plain language of health data use, so this brings us nicely to talk about this project. This is called the Plain Language About Data Project, or as in short, we call it PLAD. The main idea of this project is that we know members of the public really care about how their data are being used, but it's often difficult for them to understand what is happening with the data that's collected about them. And this is not limited just to health data. So even if you think about visiting certain websites, it could be Amazon, it could be a clothing website. Oftentimes you'll get prompted to put in, your name or other personal information, and then you'll get prompted to accept the organization's privacy policy. And oftentimes this document is hundreds of pages long, full of jargon, and no one reads it. So we believe it's extremely important for organizations to be transparent in their communications about data collection, use, sharing, and reuse by presenting plain language communications that are tailored for an individual's needs and preferences. So I really like this quote there that's in green on the slide. You can't have trust without transparency, and you can't have transparency without plain language. So this really reflects that notion of public trust in health data use, and that plain language is really at the core for and essential for public trust. So this is a research study, and the team is made up of over 40 individuals from Canada, the UK, the US, Australia, and it includes as well a lot of members of the public who actually helped co-create the study design and the methodology. So the main objective is to really learn more about what people want to know about how their data is being used. And we'll just get into a little bit of detail about what we're actually doing in the study. So there's 2 stages. The first stage, we're going to conduct a series of virtual generative dialogues. So we're going to convene groups of people to have conversations about what they want to know about how their data are being used. So these conversations will be supported by a dialogue guide that presents background information in plain language, as well as illustrations about how and why data are collected, shared, used, reused. So you can see one of the illustrations there that we have had created to kind of show that, plain language for data use. The output of these discussions, what we hope, is going to be a list of bullet points of information about what people want to see in what we're calling their personal data notice. So a data notice would be, like I just mentioned a minute or so ago, what an organization would present to you upon collecting your health data. So it could include things like who's accessing your data, what are they going to do with it, what data are they actually collecting, how long are they going to have it before they delete it, are they going to sell it to a third party, all those sorts of things. The second part of the process is going to be an iterative process using the Delphi method, if anyone is familiar with that. So a larger number of participants in this stage are going to actually construct and refine their own personal data notices, either using an online survey or another accessible format. So they'll be provided with that list of bullet points and information that were generated during the virtual dialogues, and then they can kind of drag and drop what they would like to see in their own personal data notice. So what we hope in that process is that we'll actually get some examples of personal data notices that we can use, one in the manuscript for the paper, and also share via different mechanisms. And ideally, organizations could use these personal data notices as templates in their own communication with the public. That would be really cool. So in terms of where we're going with this project, we are currently finalizing ethics for it. We hope to start recruitment for participants for both stages, I would say in the next 1 or 2 months. So if you are interested in being involved in the project, feel free to reach out to me. I can put my email on the chat, or you'll probably have it in the follow-up email, and we can keep you on the list. Brian, do you want, again, I know you're a part of this project, so feel free to add your comments here as well.
Yeah, absolutely. And I can say that there is a reason why I chose these 2 projects in particular to be a part of, because I really feel like these 2 are really foundational in shaping how research is or even patient outcomes and interventions are done in this space, because it really requires an understanding of what this data space is actually like. And again, I can say this, it's confusing for me at the best of times, and I consider myself a techie. So I think plain language and communication is so integral about building both trust and transparency. And then social license is such a big part of what the large population deems acceptable use of data. And without those 2, I think strong initiatives are really tough to plan, particularly when we do focus on equitable efforts, because the risk is always there that we miss something that hasn't been said already. So yeah, I really love these projects, and I think they are very foundational. So I can give a thumbs up, and I'm happy to be a part of them.
Thanks, Brian. Again, we do really appreciate that feedback. And a thought just popped in my head too, because we have been talking about, again, recruitment for this project. Again, how do we get the most diverse voices possible? And I know there was a comment earlier about youth. And originally our plan was just to have kind of general, a couple of different virtual generative dialogues, 2 hours long, a couple in French, a couple in English. And when we reached out to all our team members, which I said it's a very large team, some of them said, well, I think you might need to have a youth-focused dialogue, because again, how you engage with youth and how you communicate with youth is very different. And also, I think you might need to structure your dialogue a little bit differently. Youth probably aren't going to they're going to be intimidated by a 2-hour dialogue. So we ended up changing the method of the project based on this feedback from team members, which included members of the public. So now we're having a youth-focused dialogue with a different facilitator. And even in terms of that consent for the research study is different when you're dealing with youth. We're having it be an hour instead of 2 hours. So just another example of how we are, again, trying to ensure diversity in recruiting for these different projects, and how we're really trying to collaborate with members of the public when we're creating the methodology for these projects. So just something I thought of because it was relevant to what we discussed. I think that was all both Brian and I had to say. I don't want to speak for you, Brian, but I know we have just a couple minutes left, so we'd be happy to answer any other questions.
Yeah, yeah, that's everything from us, at least. Thank you.
So thank you so much, Julie and Brian. I know that we plan to keep more time for questions this time, but I actually kind of like the way the format turned out. It was a great discussion throughout. And it sounds like Isabel may even have changed the agenda for the PAC meeting tonight. So that's exciting. We have just a couple minutes left. So I wanted to, Isabel, not to put you on the spot, but I had asked you to hold a question for later. And if you haven't had a chance to ask that yet, feel free to unmute or drop it in the chat. Well, ooh.
Honestly, it totally left my brain now.
Oh, sorry.
I got distracted by all the great content. Oh, don't be sorry. What a great presentation. It's really great. Thank you.
Oh, that's wonderful. So I'm just going to, with the last couple of minutes, put up a couple of thank yous, of course, to our presenters. I don't know if everyone can see that now. Julie and Brian, thank you for sharing your experience, and to everyone who's on the call for discussing and being part of today's conversation. I also want to thank our behind the scenes helpers, Shelley and Carla, who helped make today run smoothly and get the word out. I am going to, and of course, thank you to our funders who make today possible. And then I'm going to stop sharing and drop a link in the chat. This is the link to the evaluation for anyone who wants to give us some feedback while the memory's fresh. And there were a number of links and activities we mentioned throughout. So I'll include that along with the evaluation link in a follow-up email for people who are interested in learning more or want to get involved or reach out to Julia or Brian. And I think that's it. Thanks everyone for joining us today.
Thank you, everyone. Again, I really appreciate all the good discussion and the comments and the feedback. And Rachel, I hope you remember all the follow-up because I might forget some of it. So just poke me and all.
I've got some notes. I'll check it and make sure everything gets to the email before we send it out. Oh, and that will have the link to the recording as well for anyone who's looking for that. Okay, thanks again, everyone.